Good afternoon, good evening, good morning. Welcome to Facebook's Neurology for Vets Journal Club Live, wherever you're tuning in from, where we ask an author of a recently published study to present to us in their own words and give you a chance to ask some questions at the end. These webinars are sponsored by Hallmark Veterinary Imaging, so thank you very much to them for this. And today we have the great pleasure to welcome Dr. Javier Espinosa, who is going to talk to us about his study on occult tethered cord syndrome in dogs. Pretty challenging diagnosis, so eager to find out what he got from that study. But before we get started, let me introduce Javier to everybody. He graduated from the University of Cordoba in Spain in 2014. And shortly after graduating, he completed a 2-month externship at the Freie Universität Berlin, Germany, and a rotating internship at the veterinary teaching hospital of the University of Concepcion in Chile. Apologize for my accent to those people who think I've just butchered that. He then spent 2.5 years in the first opinion practice across southern Spain and Gibraltar, and in 2018 he moved to northern Spain, where he completed a general internship followed by a neurology internship at the referral hospital in Dauchu in Bilbao, subsequently remaining as part of the neurology service. In 2021, in June, he relocated to the UK to join Pride Veterinary Referrals, undertaking a neurology internship and subsequently commencing an ECVN residency, which is where he is now and nearing the residency completion. So welcome, Javier.
Thank you so much.
Thanks for coming. And without further ado, we'll let you get on and tell us about your presentation.
Perfect. Thank you. So first of all, thank you everyone for connecting to this webinar. So I hope you will enjoy it. And thank you, Laurent and Simon, for the opportunity to present our paper. So today I'm going to speak about occult tethered cord syndrome based on 30 cases. So as a brief introduction, tethered cord syndrome refers to a rare congenital or acquired condition that causes abnormal position or traction of the spinal cord and meninges. It can present with a wide variety of clinical signs and is usually seen together with some congenital malformations, and you can see in the picture on the left. This has been reported in veterinary medicine in both dogs and cats. We have this really nice recent review about the presence of tethered cord related clinical signs in dogs with congenital malformations. There is usually in association with neural tube defects, and also there is a predilection for the lumbosacral region, even though they can happen anywhere in the vertebral column. However, sometimes you can face the clinical signs consistent or suggestive of this condition in the absence of any radiological support or radiological abnormalities. And this is where we suspect about an intrinsic pathology of the filum terminale. And also, it's not only just about the mechanical consequences, so the traction, it's also about a whole cascade of events that happen at a microscopic level. For example, impaired blood perfusion and hypoxia in the tissues that likely contributes to the debilitating course of the condition, and also at least partially with the clinical signs. So occult tethered cord syndrome has been reported in veterinary medicine. The literature is scarce, and there are these very well-known case reports from Annie Uriarte and Steven De Becker. And also, one of the cases was also reporting the use of dynamic MRI for diagnosis. So to understand occult tethered cord syndrome, we need to be familiar with the filum terminale. And this structure is a bit enigmatic. It was traditionally considered a fibrovascular band that was just involved in mechanical kind of actions like stretching purposes, but there is loads of literature in humans where they have thoroughly investigated the anatomy, the histology, which is quite complex because there is connective tissue, but there is also quite a lot of nervous tissue. And more recently, and very interestingly, they found also that some components of it, they have a functional role with nociceptor or mechanoreceptors, for example. And so that means that, of course, there is an active role of this structure in the physiopathology of this condition. And recently, we had the great opportunity to publish this characterization of the filum terminale in dogs in collaboration with several colleagues, and in which the team from the University of Barcelona provided us with stunning pictures about the anatomy and the histology of the filum terminale. And indeed, in this study, it was proven that this complex structure is also present in dogs. We found the features of the connective tissue with loads of similarities, but also quite abundant nervous tissue, including neurons, glial cells, myelin, nerve fibers. So this represents a baseline to compare pathological filum terminale in the future, potentially. For those that are not familiar with the structure, just to summarize, so as you know, we have the spinal cord, which is narrowing down in this kind of cone shape, and indeed that's why we call it conus medullaris. And at the very tip of the conus medullaris, this is where the filum terminale internum begins, is still kind of surrounded by leptomeninges and subarachnoid space in the dural sac. And then there is also this tip-like structure, which is the termination of the dural sac. And from there onwards, or caudally, the filum terminale continues as the filum terminale externum, which is just surrounded by the inner layer of the dura mater. So what we knew from this condition was that they tend to present with a specific localization of L4S3 or cauda that the dynamic MRI may aid in diagnosis because conventional MRI is just normal, and the presumptive diagnosis can be confirmed by surgical, response to surgical treatment, but that implies a bit of a ethical dilemma to the neurosurgeon, because of course the effect of such an invasive procedure can be only assessed retrospectively. So when we started to face these cases, what we realized is that the exact spectrum of neurological signs, so what's the variety, what's the range of neurological signs and the severity, and how do they progress with time. We also found no standard diagnostics to ensure timely identification. There was a lack of prognostic factors, and also the criteria to try and identify dogs that could potentially benefit from surgery was quite limited. So to cover this gap knowledge, we wanted to characterize the presentation, the investigations finding, in particular MRI, treatment modalities and outcomes in dogs with this condition. And also we wanted to try and identify prognostic factors to guide treatment decisions and to predict outcomes. So this is a retrospective, descriptive, multi-center study involving 12 referral hospitals across 4 countries, and ethical approval was granted by the RDC prior assessing medical records and contacting owners and referring vets. Inclusion criteria: dogs with any signalement and neurological signs consistent with that localization and unremarkable MRIs. It's the typical dog that comes to you with this very specific localization and you find nothing really on conventional MRI and in the rest of the investigations. It's worth to mention that some more subjective findings, like for example, a more cododorsal position of the conus medullaris was not considered for inclusion criteria, and also the fact that dynamic MRI was not needed to be included, but when it was done and available, it was evaluated. And then dogs that were treated medically were categorized as presumptive, which means this dog is never underwent surgery for detethering. And also those cases undergoing surgery, they will classify as responders if they got better after the surgery, and non-responders if they didn't improve after surgery, and those remain with an open diagnosis. In the exclusion criteria, any physical or orthopedic examination abnormalities that you could at least partially justify the clinical signs, they were excluded. When electrodiagnostic investigations were done, if there was any evidence of multifocal or generalized neuromuscular disease, those were excluded as well. In the MRI, if there was any abnormality, whether that was congenital abnormalities or disc-associated, anything that could justify clinical signs, excluded. To try to enhance the diagnostic confidence in those cases that were considered presumptive diagnosis if dynamic MRI was done and there was actually displacement or translocation. They were excluded as well. And then cases that underwent lumbosacral stabilization, or if they had any insufficient follow-up duration or just data. So there was this very interesting paper in Humans Medicine where they developed this 15-item scale to try and identify which dogs could benefit from surgical treatment. So any human patient exceeding 6 points in this table was considered a good candidate for surgery. So we use it, and based on this, we created our own table, and we expanded it a bit to include some other concepts. For example, the behavior, which we found to be very significant, behavioral abnormalities. And then once dogs were scored based on this table, they will classified in grades, basically, just to try to make it easier from the classification point of view. The MRIs were all evaluated by specialists in imaging and neurologists. Also, all the studies were re-evaluated by the first and last authors together with the same imager. Intra and inter-observer agreement was not calculated. And of course, the sequences and protocols varied across these institutions. Regarding the dynamic MRIs, they were mainly assessed to evaluate translocation of conus medullaris and dural sac termination, and also the change in the angle was noted to ensure appropriate dynamic variation based on previous publications, for example, in those flexions reaching as close as possible to 180 degrees. Regarding the data collection, we gathered all the information about signalments, clinical signs, investigations, and management strategies. And regarding the follow-up, they were considered either full recovery, partial recovery, static, or deterioration. Relapses were also included, where they were partial or full relapses. From the statistical point of view, we did a univariate analysis, and so we wanted to assess the relation between clinical and demographic variables for 3 key outcomes, which was the response to medical therapy, recovery status at the last follow-up, and that means whether it was a full recovery or not, and the treatment status, which means whether the dog was on any treatment at all at last follow-up. So this is the cases that we identify. It's worth to mention that we didn't screen the whole database of the hospitals that were involved, but we selected cases that we knew that were diagnosed. So we managed to gather 41 cases, from which 11 were excluded due to different reasons. And then, as I said, we had the conservatively managed ones, which were considered presumptive occult tethered core syndrome, and those responding to surgery were considered confirmed. And indeed, we didn't have any case that didn't respond to surgery. So eventually, that's why all the surgically managed cases were eventually confirmed. From the demographics point of view, it is worth to mention that it seems that the cases with a confirmed diagnosis, they had a younger age at onset of clinical signs, and also they had higher scores in the scoring system. So it means that this doggy seemed to be more severely affected from a younger age. And also from the neurological point of view, they were present in almost all of the cases. Pain was by far the most common clinical signs present in all but one patient. And then also some other quite commonly seen clinical signs was the pelvic limb gait abnormalities, behavioral changes, impaired physical activity, and urinary fecal incontinence. Also worth to mention that in the confirmed group, all the cases were progressively getting worse prior referral, so they were deteriorating, and also all the cases in this group were receiving medical treatment prior referral, while most of the cases with the presumptive diagnosis were, but not all of them. And it's just to say that the most common drugs were NSAIDs and gabapentinoids, among other drugs like amantadine and Ritalin, or even phenobarbital in some cases due to the abnormal behavior. So from the clinical point of view, as we said, the pain was quite marked in some cases with these episodes of constant turning. The dog was really bothered by the back end, almost kind of frustrated, reluctant to go for a normal walk with vocalization. They were dogs that were affected in a similar way, but not as dramatic. So dogs that were maybe just unsettled and looking to the back end intermittently and just struggling to find a comfortable posture. And some dogs as well that they had a quite episodic but intense clinical signs. This dog was having episodes only after intense exercise, but quite bothered by the back end and intermittently turning as well. From the gait point of view, lameness was a very common presenting complaint, and also stiffness in the back legs with this kind of short-strided gait and almost like an abducted posture was also relatively common. But as I said, in other cases, these clinical signs were a bit more subtle. So even though it's the same, abducted posture, short-strided gait, it was not as obvious. And indeed for the owner, that was the way the dog was walking since it was a puppy, and it was not a problem with the gait. Well, I have to say that in the physical examination and orthopedic examination, which all dogs underwent, there were no significant findings to justify the clinical signs. And then from the neurological examination point of view, this is a bit of a summary for more specific clinical signs. It is worth to mention that it was a bit difficult to fully distinguish sometimes in between what's actually an abnormal behavior as such, or what was a behavioral response to a painful stimulation. For example, many dogs, they had this sudden turning, which indeed can be just a response to pain. But the thing is that some dogs developed some more compulsive behavior afterwards, like even tail chasing. So there was a bit of overlapping in this. And then we as I said, abduction, lameness, stiffness was relatively common. And it's worth to mention as well that even though many of these dogs had pain or discomfort or dysesthesia in the lumbosacral region, not all of them responded or show it on examination. So sometimes it was more in what the owner was reported and the videos, rather than because we could actually trigger that on examination. I mean, just in some cases, because some other cases were very, very reactive overall. Anything around the back end, they were even anticipating a little bit. So regarding the MRIs, they were most of them high-field MRIs, and 28 studies were available for assessment. 4 dogs also underwent brain MRI just due to the severity of the behavioral changes and aggression. And most common terminations of the conus medullaris was L7 and S1 for the dural sac. There were 20 dynamic MRIs and 19 could be assessed, and most of them had both extension and flexion. The median angles were in alignment with what has been reported to be the requirement to be a significant change. And in any of the dynamic MRIs, any translocation of these structures was seen. There's a nice picture just to show the variation in the termination of this structure. And it's worth to mention as well that despite most of the dogs finishing around L7, as we said, for example, or even a bit more cranial, some dogs were having the conus medullaris quite caudally, actually. And of course, this is significant, or might be significant, because in humans, for example, a low-lying conus medullaris can be a sign of tethered core syndrome, and indeed would imply a conventional tethered core syndrome, because you can actually see an abnormality on MRI. This is still not the case in dogs, but it's just something we wanted to mention. Then regarding other investigations, there were not significant abnormalities in any bloods or CSF in those cases in which they were performed. Regarding electrodiagnosis, it was done in 9 cases, and in 4 cases we found abnormalities. They will predominantly affecting the tail base, and predominantly what we saw, it was spontaneous muscle activity characterized by positive sharp waves, fibrillation potentials, and here you can also see some end plate spikes, physiological. Then further imaging in some cases that had CT scans, abdominal ultrasounds, didn't yield any abnormality. And histopathology of the filum terminale was done in 6 cases, and it was mainly done to confirm that the correct structure was dissected in theater, because sometimes it's not as easy to distinguish it, especially in those small dogs or dogs with pathology in the area. Then regarding treatment, as we said, 57% of dogs were treated medically, and there were 2 dogs that were untreated, and these were cases actually mildly affected with clinical signs, mainly after intense physical activity. And so in those cases, with exercise management, it was enough to control the clinical signs without justifying daily medication. And then in those cases undergoing surgery, of course, they were all treated previously with polytherapy, with medical therapy, without a satisfactory response. And 1 dog also received 3 epidural injections of steroids. Regarding surgery, there was some variation, but pretty much involved lumbosacral dorsal laminectomy. But I said in some cases a bit more caudal, depending on the individual findings about where the filum externum was, for example. Surgery implied dissection of the filum terminale externum in 5 cases, and externum and internum in 6 cases. There were some subjective findings intraoperatively, like the thickness of the filum terminale, whether the filum terminale appeared tight, and also whether there was obvious cranial translocation once the structure was dissected. And then dural graft was used in 3 dogs. And fat was used in 1 dog, and titanium mesh was used in 1 dog as well. So here you can see just a video in theater showing the subjectively increased tension of the filum terminale externum, and also in this picture here you can see also the filum terminale externum, but you can also see that the most caudal or distal aspect of the dural sac is quite opaque and quite thickened, so it's indicating pathology in the area, while the more cranial aspect is it has had a more normal appearance. And here the filum terminale internum, you can see, so of course, once the dura is open, and you can see the translocation that occur in this case after the dissection of it. Also worth to mention that conventional MRI fails in some cases to identify microscopic or microstructural abnormalities. For example, in this case, with this 3D sagittal fiesta, we were very happy to identify an apparently normal filum terminale internum, but then in theater with the microscope we could see how the distal aspect of the filum terminale internum within the dural sac was quite embedded in this almost like fibrotic tissue, and a normal appearance with the associated vessel was only seen here more cranially. Regarding follow-up, the median follow-up was 9 months. It was longer in those cases undergoing surgery. It's worth to mention that the last follow-up, roughly a bit more than half of the patients were still on medical treatment, but the proportion of cases was much lower in those cases undergoing surgery. Sadly, 1 of the dogs was euthanized in the presented group due to non-responsive pain and severe behavioral abnormalities. Regarding those cases undergoing surgery, there was a shorter outcome with full recovery in 9 cases, around 2 months. But then when the long-term, when the follow-up was a bit longer, the long-term outcome showed a full recovery in 7 cases, because 2 dogs with full recovery relapsed. Okay, and additionally, 1 dog that only reached partial recovery after surgery also relapsed. So in total, we had 3 relapses. And all of them underwent follow-up MRI, and 2 out of these 3 dogs had revision surgery, and all of them got better after the surgery, but none of them never reached like a full recovery. Okay, and here you can also see how the percentage of cases with full recovery, which much higher in those cases undergoing surgery. And here, what you can see is all this is one of the revision surgeries with all this fibrotic tissue and adhere fat to the dural sac and the codequina. And here is a video from the microscope where you can see a quite thickened dura mater, so while we were performing the durectomy. Also important to mention that what we saw in this revision MRIs, apart from, again, the lack of translocation of the structures that we mentioned, the conus and the dural sac, was that there was almost like some soft tissue bulging through the dorsal laminectomy window, and it was somehow pulling the codequina and the dural sac upwards, and it was suspected to be the reason of the retethering, if that makes sense. Here we just see some results from cases pre and post surgery. So the same that we saw initially, with a marked improvement in the gait after the surgery, and similarly in this doggy with the initial lameness and a quite quick response shortly after the surgery while still in the hospital. In regards to the prognostic factors, it was found that the clinical severity score strongly predicted medical response with an optimal threshold of 7, which means that those cases with a score of 7 or less than that were good candidates to be treated medically. There were some parameters which were negatively associated with a positive response to medical therapy, and this was either a deteriorating clinical evolution prior referral, the presence of behavioral abnormalities, and of course higher neurological grades in this scoring system. Also, the surgical treatment was significantly associated with a full recovery at last follow-up, and also the complete discontinuation of medication at last follow-up. And other parameters that could not be assessed statistically due to the small sample size, but they were still interesting findings, were the fact that dogs within the confirmed group, dogs reaching full recovery were dogs with lower severity score as well. So it means that cases with higher scores may not reach a full recovery. And again, this was not confirmed statistically. And also the surgical target, because we saw full recovery in all of the cases that had the dissection of both filum terminale, the internal and external, but in the ones that had the externum only one reached a full recovery, and the 3 relapses were in this group. So here what you can see is that, as I said, the responders, the median score for the responders was much lower in the severity score. Also, you can see how the responders were mainly classified as grade 1s and 2, but there were no dog in a grade 3 or 4 that was going to respond to medical therapy only. And also you can see how the proportion of cases reaching full recovery was significantly higher in the surgical group. As discussion points, one of them is that there is a potential congenital origin of this condition, so a congenitally abnormal filum terminale. This is based on the fact that we saw juvenile onset in some dogs and prolonged histories, and this aligns with findings in humans because the mean age at presentation is around 16 and 24 years of age, but sometimes the history varies from a few months up to more than 10 years. So it means that they were still significantly young when they started with the clinical signs. However, we also had cases with presenting with more than 5 years even in the confirmed group. So that can represent either a more acquired etiology, like degenerative changes in the filum terminale, or a more subclinical course of the disease in those cases. From the behavioral point of view, also very important, we really found that many of these cases had significant behavioral issues. They were dogs that were already treated by behaviorists, they were already on medications like fluoxetine, and there were many dogs that were aggressive, many times triggered, of course, when they were touched. They were some dogs that they were just aggressive when they were groomed around the back end, and they were always reactive since they were puppies. Some dogs that were more anxious, some dogs that were just showing restlessness or even lethargy or reluctant to exercise. And we know how pain or chronic pain can affect behavior. We know how when a dog is exposed to chronic pain significantly, it can then progress to allodynia, for example, and with all this sensitization and wind up phenomenon. So eventually you may have a persistent behavioral abnormality, even if the original source of or cause for it is addressed. Because they can remain with this kind of ingrained behaviors, like in the compulsive cases. So we feel it's important to address these cases as early as possible to try to minimize these potential behavioral consequences. Then it's also important to say that in human, they know like the feather cord triads, which is pain, neurological deficits, and urinary fecal dysfunction. And this was seen in our cases as well. So there are some similarities in the clinical presentation. The main difference was in the urinary fecal dysfunction, but this can be an underestimation on our side because we were mainly recording dysfunction of it, like dribbling urine or dropping feces, but there are so many subgroups that they assess in people, like urgency to defecate, reluctance to defecate, or even sometimes pain. But we consider the pain during defecation or urination part of the pain assessment rather than in the urinary fecal dysfunction. And those cases were around 23% in our population. So there is a chance that actually this is an underestimation and the urinary fecal dysfunction is a bit higher. Also, we know that conventional MRI was limited, missing some microstructural abnormalities, as I explained in the previous MRI. And as I said, the low line of conus medullaris can be indicative of tethered cord syndrome, but we cannot confirm that yet. And also in humans, they also assess some more intrinsic abnormalities of the filum terminale, like the thickness or the length of it. And even though that this has been done in dogs, it's not easy to do with our MRIs. And also we have loads of variations as well, breed related, size related. We know that, for example, cavaliers, they tend to have a more caudal position of the dural sac and conus medullaris. And also we know that those cavaliers with pain and without syringomyelia, they can have a shorter filum terminale internum. So this is, of course, a direction for future research to try to optimize the MRI protocols to try to identify this condition, ideally even before having to do the surgery. So it remains an open door. From the electrodiagnostic point of view, we know that the main reason why we did it actually was to confirm that in these cases, even though they were just presented with pelvic limb abnormalities, this was not part of a more multifocal or diffuse neuromuscular disorder, and they still do this in humans. Also in humans, there are changes reported with tethered cord syndrome, like EMG abnormalities, for example, in roughly 40% of cases. So it's just interesting, and also remains an open door for future research to do this test in these cases if we have the chance, first of all, to rule out other potential, to enhance the accuracy of the diagnosis, and also to explore which findings are consistent across these cases. And also, just out of interest, in humans, they even use electrostimulation to stimulate the filum directly in theater, sometimes just to identify the filum. And of course, when there is pathology like a fatty filum terminale, there are changes in this kind of response. So we're far from this, but it's just something interesting. Regarding the surgery, is definitely the preferred approach in humans, with improvement rates up to 100% really. And it's important to say is improvement, doesn't mean full recovery. Actually, in the paper that I showed initially, from which we based our table, they were considering responders to surgery for those cases that got 1 point less in that. So if they improved in 1 point, they were already responders to surgery. And early intervention can lead to better outcomes, which we could not prove in our paper, but we believe that, for example, from the behavioral point of view, it's important to know this. And also, from the surgical technique point of view, there is a big debate about whether to cut the filum externum, internum, or both. Actually, in humans, it's quite standard to just cut the internum. There is this paper where they showed how applying tension in the filum terminale externum doesn't necessarily imply tension in the filum internum, because it was still quite loose. So by sectioning here, you're still not going to achieve a direct consequence on the filum internum. And also here is just a beautiful picture about a fatty filum terminale in people. But of course, to cut the filum internum is just more invasive, but it seems to lead to superior outcomes, at least in our paper. Regarding relapsing signs or retethering, this is an important point, because relapses, this is known as a complication, and actually the range can go from around 8% in the short-term follow-up. But however, in humans, it seems that the longer you follow up the cases, the higher is the rate of retethering, and they have even follow-ups up to more than 18 years, and the rate of relapses or retethering can go up to 57%. So it seems that this condition can be a chronic condition that can keep coming back somehow. And of course, to try to minimize this, there are some hypotheses in people, for example, to try and dissect the filum away from your entrance in the dural sac, to, I guess, to avoid, of course, like the scarring tissue in the dura has any relation with the free ending of the filum. But yeah, this is just what they suggested, and also some findings like CSF leakage after surgery, or when you're closing, can be predisposing factor for retethering. What we found as well, and we don't know if this is necessary, because we are aware that dogs with routine dorsal laminectomies, they don't need anything covering on top, but we are exploring the possibility, because what we saw in these cases in the follow-up MRIs was this bulging tissue almost pulling upwards the structures in the area. So we tried to cover with titanium mesh initially, and also with dural graft on top of it. However, in one of the cases, and it was afterwards in this paper, it did relapse, and there was lots of fibrotic tissue going through the titanium mesh, actually. So to try to avoid this, we also use these PVS plates. So it's the same material as the suture, and it's going to be reabsorbed in few months. But we are just exploring the possibility. We're not sure if this is extremely necessary, if it really has an impact, but it's something we are currently doing to try to minimize chances of relapses. As limitation of the study, of course, this is a retrospective with many referral hospitals involved, which means there was lots of heterogeneous data regarding descriptions, even surgical reports or protocols like in the MRI. There is a bit of a selection bias as well, of course, because, for example, in the presumptive group, we only choose the cases that that had a fixed position of the conus and the dural sac. So that implies that we are already kind of selecting these cases. And also there was a lack of histopathology in 5 cases that underwent surgery. But of course, histopathology was not an inclusion criteria. Also, of course, in the presumptive group, despite thorough investigations, despite a strong suspicion of this condition, we cannot still confirm the disease, because we didn't see the response to surgical detethering. And then, of course, it's a small sample size, precluding multivariable analysis from the statistical point of view. We have short-term follow-ups, which means that we want, of course, to follow up these cases for longer, 3, 4, 5 years, and maybe this kind of relapsing rate will be higher, like happens in people. And also this novel clinical severity score should be, and the grading system should be validated externally with independent groups of cases and in larger cohorts to see if there is consistency. So as conclusions, is the first comprehensive characterization of this condition in dogs, and we believe that this condition has been underdiagnosed. Although, of course, we don't want to fall into the fashion of everything is going to be occult tethered core syndrome now. So we want to remain quite strict and thorough as possible with our diagnosis. Also, it appears to be a painful juvenile onset progressive or debilitating condition. Surgical intervention seems to be significantly associated with positive outcomes, although relapses are possible. The clinical severity score and grading system were proved valuable, at least in predicting those cases that were good candidates to be treated medically. And obviously, larger prospective studies are needed to validate all these findings. So I wanted to thank all the co-authors involved in the paper and all the referral hospital. I wanted to thank to my supervisor, Chris, for his help. And yeah, that will be it. Thank you so much for your attention. And I'm happy to respond to any question.
Thank you very much, Javier, for this excellent presentation. We're going to take a few questions.
Yeah.
Let's dive in. One is actually about surgery and is simply, any tip you've got to recognize the filum terminale. I mean, when you first do surgery at that level, you do dorsal LS, things get really scary and confusing.
Yeah, so to be honest, in some cases, it seems more straightforward. I think in bigger dogs, for example, is more obviously recognized. And also there is this kind of vessel from the spinal artery that follows the filum terminale internum. So sometimes it's the vessel that helps you actually identify it. But also what we found necessary or quite useful is the use of microscope, surgical microscope, especially in tiny dogs, in dogs with 3-4 kilos, and in dogs actually having pathology in the area, because even if you are ready to recognize a normal filum terminale internum, sometimes it's just pathological, so it's not normal, and there is fibrotic tissue in the area. So the microscope really helped us to be more confident at the time. And still in some cases, we were not 100% sure, but quite close to it. But that's why we always send the samples to the lab to confirm anyway.
Thank you. There's a question about if there's any, place for hydrotherapy, physioacupuncture in this patient, either as a medical management, as a conservative or post-op.
Yeah, so we didn't look specifically into this actually, but definitely it can help. These cases, definitely when they are exposed to very chronic pain, they will benefit from a multimodal approach. And we are always happy, of course. Some cases, for example, that I didn't mention, that is in the paper, they had quite marked atrophy, for example, or significant atrophy of one or two of the pelvic limbs. So those cases were having ongoing physiotherapy, and also acupuncture can help as a complementary treatment as a complementary way to treat pain together with medication. So definitely, I think is definitely place for it, and it can be helpful for sure. But we didn't compare specifically this because not all the cases were having it in both groups.
And the question, I mean, before the webinar, we talk about lameness. So one question from Anna is, we've all seen this dog, especially Terrier breed, with the skipping gait on one limb. Orthopedic surgeons are scratching their head what it is. We ask the neurologists that usually say it's nothing. We MRI. If there's any place here to, could be.
I see what you mean, because it has been reported actually in these little terriers, right? This unknown origin skipping gait. We have not seen, skipping gait or even patellar luxation was seen in 2 or 3 cases, if I remember well, from the orthopedic point of view. But for us, it was not a common presentation. So the lameness that we saw, it was more like in the case of the video that I showed. It was not like the fact that they were holding the leg for a few steps and then they were back to normal. Indeed, the lameness that we see more commonly were more chronic lameness, really, like quite consistent lameness. So those dogs were not having a normal gait and then skipping the gaits. So I guess it could remain a possibility, but it's not a common feature that we did recognize in our patients.
So probably for our orthopedic surgeon that are watching, when will you start thinking about occult syndrome with a lame dog? Or which dog you will say doesn't fit that? I will not have it in my radar.
Yeah, it's a very good question. And indeed, a significant amount of our cases came through the surgery department that were internally referred to us, because those are dogs with unspecific pain. Some dogs can also be a bit reactive on hips extension, but mainly when those cases had a quite normal orthopedic examination, and even if they are a bit reactive on hip extension, you cannot justify that from the imaging point of view. For example, in radiographs is where this come into a place. If on top of that, when we take over the case, we find that the dog is relatively young, we find that the dog actually always had some abnormalities, including behavioral abnormalities, is when we start to be quite suspicious about the condition. And eventually, if there is nothing from the orthopedic point of view to justify the clinical signs, which in some cases are quite severe for what the orthopedic tend to see, because even a dog with a very bad hip dysplasia is not usually showing the clinical signs at a young age that these dogs were showing. So there are few boxes that when they tick it, is makes us to do the MRI probably and to take over the case to investigate whether there is any neurological abnormality.
But because you find nothing on MRI, when...
Exactly, that's the difficult part. So that is when it comes that we started to do, as a protocol, the dynamic studies in these cases. And then if on top of that, you manage to rule out any alternative diagnosis, which is very important, nothing from the orthopedic point of view to justify the clinical signs, nothing on imaging, nothing in the rest of the investigations, including electrodiagnosis, then is when there is a discussion to have with the owner about whether surgery can be recommended or attempted. Of course, it's always a matter of really manage the owner's expectations with these cases. There are tricky cases, there are a bit enigmatic cases, and most of them, they come to us with a very chronic history already, so the owners are a bit desperate. Some of them were even close to be euthanized, really, because they're aggressive, they're in pain, they don't know how to help the dog. So it's a big discussion to have, but the cases in which we did surgery were normally cases that were quite affected. So it was a bit of a, for some owners, were a bit of a desperate kind of option, or as a last chance, really, for those cases. But of course,
you expect a long duration, so they will start usually at a younger age.
Normally,
so if you got
yes.
a 4-year-old dog being lame,
yeah.
being lame for a few months, is it something that you consider? Or?
Yeah, and indeed, as I said, even in the confirmed group, we have cases coming to us with 5 years age. But normally, when you start to dig in the history and you speak to the donor and you ask about more chronic, even if subtle deficit, like for example, the dog doesn't enjoy going for long walks, is sometimes struggling to jump onto things, sometimes it's leaking compulsively around the back end, and there is no anal glands issues at all. So sometimes clinical signs are very subtle, and indeed, in those cases, we may just treat it medically because the dog is not affected enough to justify the risk of a surgery. But in those cases where they are so affected that the quality of life is impaired and there is not alternative explanation, and you got your MRI ruling out everything else, and also the dynamic MRI with a fixed position, then surgery has to be considered in that dog, I believe.
Just two more. One is, how can we explain lateralizing sign with a midline condition?
Yes, that's a very good question, and we are wondering about it because we have lateralizing signs in this, in regards to the atrophy, for example, or the lameness. It's difficult to explain, but I have seen that in humans, in the human literature as well, where, for example, they will have a tingling sensation in one leg. So eventually, I think even though this is a midline structure, if there is an abnormality in the area, even though if that's just proliferation of fibrotic tissue, lack of elasticity, there is a chance that eventually there will be some lateralization, but it's difficult to give a proper explanation because it's not that we can demonstrate that from imaging point of view. But also from electrodiagnosis point of view, we saw that some dogs, it was very anecdotal, for example, but having abnormalities in motor nerve conduction, they were mainly in one of the back legs compared to the other. But the most of the findings were midline, like in the tail base, for example, from the electrodiagnosis point of view. And
the last question, mostly from me there. I struggle when I assess dynamic MRI to know the boundaries of where does the conus medullaris end and where the filum terminale internally start, considering that the thickness of, I presume they are millimeters or even less. Considering that the slices are 2 millimeter, how do you know where one start, when one stop? I struggle with that.
And I think we all struggle with that. I think, of course, it's much easier to know where the dural sac is finishing, that's for sure. But then regarding the conus medullaris, the best way that we found is to do the 3D fiestas in sagittal and then reconstruct. So then in the transverse reconstruction, you can try to follow the change in diameter. So when you have your spinal cord is narrowing, and there is a point where that diameter remains static, still within the dural sac, still surrounded by CSF until you get your dural sac. But of course, there is some millimetric subjectivity and difficulty, and that's one of the limitations that we have. That's why we need more refined protocols. We need to try to measure thickness, length of the filum terminale, because here we are just talking about whether there is translocation or not, for example, but we are not talking about maybe it's moving, but it's not moving as much as it should, for example, or maybe it's shorter than it should be. So there are a few things that we still to rule out or to evaluate, but to your question, the best way is with the 3D reconstructions and try to follow it transversely.
And those cases that were dynamically imaged and were assessed to be fixed, was there any leeway given to movement? Was 1 millimeter okay, 2 millimeters okay, or was it?
No, for us it was at a specific level. Of course, there is some range there because, for example, we could say the dural sac is in cranial S1 in this case, and the conus medullaris is mid L7, for example, and they were both just there. Of course, there is a millimetric variation, but in those cases they were looking pretty much in a similar position when you reconstruct and you put both pictures together. So both sagittals, both transverses is quite the same, really. And of course, we know based on the papers, for example, in the Beagles with dynamics MRI, that there is unexpected translocation, and it's obvious to see that. And so, of course, this is what we want to investigate further in studies about specific markers, MRI-wise, of this condition. But it seems indeed quite static, if that makes sense.
I have just one more question. Sorry to keep you going, but when you looked at the behavioural signs, it's kind of an extension of what Laurent had asked. Let's say now you're comfortable thinking this dog could be a tethered cord. Were there any behavioural signs that stood out that you could use that would differentiate it from lumbosacral disease? Obviously, you've used your clinical reasoning with the age and maybe the breed, and you're putting some of those things in there. But was there anything with all of those dogs when you looked at the behavior? Because I found those videos fascinating, particularly the I don't see a lot of lumbosacral dogs quickly turning around and biting again like that. Were there any behavioral signs that you could say that's more consistent?
I don't know if we could say whether any behavioral abnormality was more kind of pathognomonic, because eventually they are just painful in the area as an LS does. So I think it's more the fact that the behavioral changes are a common finding in this condition, and if you have that in young dogs, for example, and on top of that, retrospectively, you know that they don't have LS on MRI. But just to say whether anxiety was more obvious, for example, is difficult to say. But subjectively, dogs with LS disease coming to us, they tend to be a bit older and they can be more reactive on palpation. It's very interesting in these cases that they were showing quite consistent dysesthesias, like even leaking or mutilating in some cases, the perineal area, the tail, and so on. But then on examination, they were not showing the obvious pain, or on the other hand, there were dogs that were completely anticipating. You could not get anywhere near the lumbosacral region because they were just having quite a lot of allodynia. And in some cases, for example, the owner reported how just going or touching roughly, you could cuddle the dog everywhere, but if you go to the back end, it can become even aggressive, even with the owner. Yeah, specific or pathognomonic, difficult to say, I guess.
Yeah. Okay, thanks.
To wrap up the talk, I think Conrad Jurina summarized very much.
Okay, that's good to know. I appreciate it. I mean, we just hope this is a useful study. Of course, there is still too much to learn from it, but it really seems, and especially when you see these dogs before and after surgery, the dramatic change, you actually, of course, believe that something is going on there. And we know lots from humans, but we are still far away in veterinary medicine, but we are in the process.
Thank you very much.
Thank you so much. Thank you, everyone.
Simon, you got the last word.
Yeah, thanks very much, Javier. A fantastic presentation of your study and really helpful to hear that. So thanks for giving up your time for this. That's
Thank
great.
you so much. No worries.
Thanks also to Hallmark Veterinary Imaging for supporting today's webinar. A recording of this will be available as a video and a podcast on our website, which is web-vetneurology.com. Join us at the start of December for the last Journal Club of the year, a pre-Christmas edition nonetheless. And until then, it's goodbye from me and Laurent. Thank you very much.
Thank you so much.
Thank you, Javier.
You.